Welcome to Connected Intelligence, a podcast about all the things we bring to work that aren't actually about the work. Join us in conversation about the building blocks that bring complex ideas to life, not the code, calculations, or research, but the bonds between teammates, the connection to your purpose, and the character that you build along the way. Welcome back, listeners. I'm your host, Sonia Senek. This episode brings back our recurring segment, Going Viral with Dr. Rosella, because the list of things we bring to work can sometimes include viruses. The COVID-19 pandemic has transformed how and where we work and made us all aware of the importance of public health. So we invite epidemiologist Laura Rosella to chat about the state of global public health. In this episode, we discuss the current state of COVID-19, Dr. Rosella's new program, AI for Public Health, and robot doctors. Professor Laura Rosella is a Canadian epidemiologist and professor at the Dalla School of Public Health at the University of Toronto, where she holds a Canada Research Chair in Population Health Analytics. Laura is the principal investigator and scientific director of the Population Health Analytics Lab. She's a member of the Royal Society of Canada's College of New Scholars and the inaugural Stephen Family Research Chair in Community Health at the Institute for Better Health, Trillium Health Partners. Laura has authored over 250 peer-reviewed publications in the areas of epidemiology, public health, and health services research. Her work has been featured in major news outlets such as Forbes, Newsweek, Reuters, CBC, CTV, The National Post, The Globe and Mail, and the Connected Intelligence podcast. Please enjoy Going Viral with Dr. Rosella, in person this time. Laura, it's such a pleasure to have you back on the podcast. Welcome.
Oh, it's so great to be here in person.
Yeah, in person. Safely distanced, of course.
Always.
So let's start there. COVID-19. It's been around now for several years. In its current form, what do people need to know most about where it's at?
Well, I like to think of what's changed and what hasn't changed, right? So what people need to know is that COVID-19 is still a serious respiratory infection. The things that we did to protect ourselves before, distancing, vaccination, masking, still work. If you have comorbidities or are vulnerable in any other way, you're more likely to be at risk, and you should take extra steps to protect yourselves as well as others around you. So all that remains. What has changed, which is making it a little more complex, is the background risk for every individual now is more complicated. So before we had COVID vaccines, everyone was at risk. Most people had not been infected. It was very clear what needed to be done to protect individuals. Many people did get infected. Unfortunately, many seriously ill and die. We had vaccines, hugely successful, safe, effective. We had boosters. We had multiple waves. We had multiple variants. So right now, everyone's individual risk is actually a little different. Mm-hmm. So the decisions of what protective steps you need to make really depend on your situation, your background, how many vaccines you've had, have you been infected, who's around you, who's vulnerable. So it's good to talk to a medical professional if you have any concerns, but also keep in mind that the way we protect ourselves hasn't really changed.
And so it sounds like people should take a little more of a personalized approach to how they manage their cold and flu season coming into the holidays and coming into winter, staying indoors a lot more in Canada. What's the best source of information for them to learn about that?
Right. So one thing I will say, I always worry a little bit about saying personalized approach, because personal doesn't mean what you do doesn't affect others. So we do have to think about many other people out there, and it's still a respiratory infection that can affect others. But I would say it's just a more nuanced risk assessment than we had before.
Right.
But what people should do, they should wash their hands. They should stay home if they're sick. If you have symptoms, they should test. Testing actually still works. Although, if you have symptoms and you're sick, you should stay home. You should make sure you're up to date on your vaccinations. Those are all the things that we should be doing really all the time right now, and as we go into every respiratory and cold season.
So a new report published by Public Health Ontario said that since 2020, Ontario has administered over 38 million vaccines with an adverse incident rate of 0.06%. Can you speak to what that number means relative to just vaccine performance in general?
Well, first of all, it means we have very safe and effective vaccines. And it's not surprising We knew the safety and efficacy of the vaccines from the randomized control trials. We then were able to see how it worked in the real world, thanks to data that we now have collected. This is one of the most amazing things to me that people may not realize, that we have these mass vaccination campaigns happening in real time. And because we're able to capture this data in real time, we have very precise data on who's been vaccinated. We have very precise data on lab confirmed COVID, comorbidities. We have a very strong adverse reporting system for vaccines. So we're able to say, yes, we know from the very careful done studies that it's safe and effective, but then in the real world, in almost real time, we're able to confirm that. So it's just amazing to me from multiple levels. I'm amazed by the science that created the vaccines that were so safe and effective, but also how well it's worked at the population level, and just given us that really reassurance that these vaccines are safe and effective and continue to be so.
And is this the first time where we've had this type of really broad data capture around the world on a vaccine's performance?
Yes, we have had it before, but I'll say not consistently. So you might have one health system in one jurisdiction in one country have really detailed data, but we haven't necessarily had it in this broad scale at the individual level and linked to other data that we can control for other factors as well at this level. And we have it from around the world. So it's just hugely reassuring, and it's really strengthened public health's ability to monitor these vaccines in the real world. You know, this happens with drugs quite a bit. So when a drug goes onto market, we know how it works in trials, but then it goes into market, starts getting prescribed to different groups in different ways, and we see what happens in the real world. And now we have that for vaccines.
Okay. And in the last couple of years, some things have stayed the same, some things have changed. You also started a brand new program called AI for Public Health, which is focused on building capacity in AI and big data skills for transformative change in addressing population and public health challenges and understanding how these tools impact health equity. So a really incredible application of machine learning and AI to your area of research. Can you speak a little bit about the inspiration for starting AI for Public Health?
Absolutely. So I'm very excited about this program and its potential for impact. Obviously, we've been hearing a lot about AI, especially in the last few days, but just in general. And there has been a lot of focus on AI in health in general, but not a lot of focus on AI and particularly public health, which public health is about preventing things before they happen. It's about working on populations instead of individuals. It's not really about detailed individual medical, clinical information. It's about what happens in our everyday lives. And so it's quite a bit different. And the way we use data in public health is quite a bit different. So me and many of my colleagues from across Canada who are big believers in data for decision making came together and said that we really would love to see specific training and capacity for the public health community. And we know the public health uses data. I mean, we just talked about a really great example of that, but we've been doing surveillance for infectious diseases, for mortality in public health for 600 years or so. We've been doing it on very crude data, but now we've evolved to lots of sophisticated data. And there are lots of ways we can take advantage of advances in data and tools for the work that we do in public health.
What types of projects are coming out of this initiative? What types of areas are you seeing AI being applied to public health or population health problems?
Yeah, this is a really good question because I will say also there's a lot of concerns about how AI is being used, and in public health we also have a lot of concerns, which is why we need a tailored program, but I'll probably talk about that a little bit later. But in public health, we think about the sort of core public health functions, which is to understand diseases in the population, predict how diseases or epidemics are going to happen, or even chronic diseases, and then think about why things happen, which you can think of as a causal question. And then maybe even some automated tasks, just processing data and things that we do in public health. So in those streams of work, the biggest opportunities now is that we can understand what's happening in the population, what diseases are affecting who, where are areas of vulnerability, but we can use more data and data we never had before. So a very simple example that's a very typical public health example is there's food-borne outbreaks, right? We know that people can get sick from what they eat. There's recalls. We see these all the time. It's very important that we
Salmonella.
Salmonella and cantaloupes this week.
That happened. Yeah.
There's a recall out right now, for example. And one of the things that happens is you get a lot of text-based data on different when these investigations are happening. So very quickly, using, let's say, natural language processing, you can identify that data and try and figure out what the source is and get to it quickly before many people get sick. It's a very, simple example, but public health does lots of these types of things, tries to sift through data, find out what's happening, how many people are sick, and what can we do about it. So we can use different data and different methods using AI tools to do that more quickly and efficiently.
So in this case, they would be looking for cantaloupe 0.
Yeah.
Where did it start?
Where did it start?
Amazing.
And where they'd be looking at reports and finding very quickly through algorithmic approaches that cantaloupes keeps popping up, as opposed to the more manual ways of doing that type of investigation before.
And in the past, would it just take a tremendously longer amount of time to do this?
Yeah. Yeah. I mean, that's really what it's about. When I talk about AI and public health, I like to emphasize we're not necessarily doing new things. It's about how we're doing them more efficiently and we can scale them.
Mm-hmm.
So this would require a lot of individuals doing this manually, would be slower. The reports may come in through faxes or other types of ways. And maybe as that's digitized, we can process it more quickly. There still needs to be a human in the loop. I don't see a lot of applications that are going to be purely automated, but it's about being a helper to the work that public health's doing and leading.
And do we have the skills distributed across the country or around the world to really apply these new tools to the work that we previously did in a new way? What's that gap like?
Yeah, so the answer is no. And that's why we created this platform. So most people are trained that are working in public health now. AI didn't exist. The data that they're now able to collect that's being digitized wasn't digitized before. And the tools that they use to analyze that data were very different than the tools we have with the advances in machine learning. So this is really an opportunity to build capacity. And the other important thing is that they have important content knowledge that they can work with people with these capacities to build that. So that's really what's driving us, is that we noticed there was a capacity gap. A lot of people think, okay, well, we just changed the way we train people in school. So people that work in public health often do a public health degree training. Well, by the time that works its way through university and college degrees, it's decades, right? So what can we do now? And so we said, let's build training programs. Let's support short courses, rapid upskilling, workshops, those types of things to fill the gap. And one of the reasons I'm also really passionate about this is because public health is funded, mostly public sector organizations. And industry has really taken up AI tools in a big way, and they're miles ahead. And so I'm seeing this divide. And so that worries me, because the work of public health is what makes our society healthier. So if public health is behind with some of these tools, that means it actually affects everyone in society. Even if you don't work in public health, even if you don't think about public health, we won't know about those diseases that much quicker. We won't be able to process data that much quicker, and that affects everyone's health. So that's really what fueled us to build this program.
And are you seeing in the private sector AI being applied to public health? Are you seeing in the private sector health-related technologies, like AI being applied to health-related technologies that are advancing much more quickly than the public sector? Are you seeing a speed difference?
I'm definitely seeing AI applications in the private sector move much quicker. I will say not necessarily in the health space, because they still have to work in the context of health. And that's the hardest step, right? So building the technology, lots of companies are doing that could have health applications, but very few are actually deploying it in health setting. This includes healthcare and public health. And the reason why is because it's a much more complex environment. There's a lot of perception of risk. People need to be comfortable with how the tools are used. There's concerns about bias. and increasing health inequities that all need to be addressed. There's regulation. So I would say the technologies are being created. Are they actually making their way into healthcare? Very slowly.
Mm-hmm. And the students that are coming through your AI for Public Health program and the scholars that are coming through, is there a few examples of projects that they're working on that you're really excited to see coming to life and where you're seeing new tools and skills being applied to pre-existing problems in a new, innovative way?
Yeah, definitely. I mean, the scholars working in this space are so impressive. So first, I will say that they're tackling new problems. So there's one of our funded scholars working on cyberbullying, for example, which is a new problem, and it's a big problem. It has serious impacts on mental health, and being able to detect and address cyberbullying. It's new data. That's one example that comes to mind. A lot of people in public health work on environmental exposures, so air pollution or even built environment and green space. And the way those studies used to be done is, and still are done to some extent, you sort of measure or have some measure of the environment. Well, now you can use convolutional neural networks, and you can actually take images of the environment and really process those exposures a lot better. And then another project that comes to mind is looking at some impacts of respiratory infections, including things like COVID, and actually unpacking the heterogeneity in the who gets sick. So someone gets sick and they have some kind of long-term effects of that. Instead of thinking of it as just one group, there actually might be distinct groups. And with some of these advanced methods and some of these advanced data that we now have, we can start realizing different groups that might mean different treatment, different implications. So those are some of the things that come to mind. And I will just mention one more. A few of our scholars are looking at the ethical implications of how we apply AI in practice. So what are some of these ethical issues and how do we sort through them? What are the frameworks that we need to do that? And that's also really important work.
We hear a lot about the importance of a quality data set feeding into a model, and that sometimes the data can be so heavily skewed to one certain population or one geography that it doesn't appropriately represent, a more broad or diverse set of people. What types of research is going on around that work on data sets and the importance of diversifying them and providing equity in these types of outcomes?
Yeah, great question. So there's a lot of attention being placed on algorithmic bias.
Mm-hmm.
And this is this idea that a data set trained on one particular population may be biased in important ways and potentially harmful ways if you try and apply it to another population. So one way to fix that is to ensure that you're training models on the most diverse data as possible, as many different people as possible. There can still be issues in the data in terms of how it's collected and who actually gets into that data set and who doesn't. One classic example is that we train a lot of models on healthcare data. Well, who gets into healthcare and who gets seen by a practitioner is not random.
Mm-hmm.
We know there's lots of barriers, and those barriers are not random. And there's certain groups that are structurally affected more than others. And all of a sudden the models are biased, and that propagates bias. So that's definitely something that is a huge focus in public health applications, because at the core of public health is thinking about a health equity. So what's happening now is, the good thing is people are more aware of it,
Mm-hmm.
but we've moved away from just being aware of it to actually thinking about methods how to measure it. So ensuring that looking at algorithmic bias is actually assessed as part of model validation, not just if we predicted this, did it get it right, which is pretty much how machine learning usually works, but actually did it get it right for important subgroups.
Mm.
And actually maybe some standards on this to make sure there's minimum standards, and actually some ways to mitigate against it. But we still have the problem, which I call selection bias into data, which is why I want more public health people working in AI, which is who gets in that data and who doesn't,
Mm-hmm.
who uses social media, who uses Twitter that we're training these models on. That's a huge determinant of the information you get out of it and how you can use it. And so we really have to work on that.
So just to work off your earlier example, in the case of cyberbullying, it would be a subset of people who actually are on Twitter or on these systems that would have selected in. So you're not actually getting a broader view.
That's right. And a lot of one of the big areas in public health is using social media data to do surveillance in terms of understanding where there may be at-risk groups. So going back to the food example, can you use anonymized search data
Right.
or Twitter data to find out where there might be a foodborne outbreak if people are...
Right. I thought you were going to say, is my cantaloupe tweeting? Which,
No, the cantaloupe's not tweeting, but people might be tweeting about
right.
being sick and what they just ate
Yes.
or where they just went, and they've actually been pretty successful at being able to do this. The problem is, though, a lot of people are getting sick that aren't tweeting. And who are those people?
Right.
And if these methods are allowing us to get to those people better and help, then that means we're potentially missing people that aren't on Twitter. So we always have to think about that. And this is why it's never a sole solution. It always has to be paired with, multiple approaches to understand what's happening in the population.
You were recently awarded a CFAR grant to apply AI to diabetes data sets and research. Can you share a little more about that?
Sure. So we've been working in the area of diabetes prevention for quite a while. And our premise and our idea, which has worked, is that we have a lot of data on the population. And we know who's at risk for developing diabetes from this data. You can predict that quite well using existing data. And you can also predict who will likely experience a complication. The reason why that's important to know is because if you know who those individuals are, then you can go in and act and try and prevent the bad outcomes from happening. And the solutions can be anywhere from, population-based solutions like changing the built environment to encourage more people walking to prevent diabetes. We've used our models to show that. Or it can be more targeted outreach for closer monitoring to prevent complications. So the traditional way we've been doing this for a while. We've been able to predict it for a while, but we've been recently using machine learning methods to do this. And the reason why that's been an advance is because we can use much more data and we can actually get quite a bit more accurate. And we can bring in data sources that we couldn't bring in before. So more complex data, more accurate predictions, that's all a good thing. But this grant isn't focused on the models. The models are working well. We've been able to validate them. It's really focused on how do we put them into practice. And putting them into practice involves not just the models, but the users of these models. And as, data scientists, we can come up with all kinds of great ways that we think these models work, but in reality, someone has to use them. Either it's someone in public health doing planning for prevention, or it's a healthcare worker, and it's a clinic. And so we're doing a really thoughtful way of thinking about how do these models land in those environments? How should they be presented? How can we co-design a way that they work into the workflow of those different settings? And most importantly, how do we do this responsibly? So what I mean by responsible AI is all those things I was just talking about. We know that it has to be transparent. It has to be reproducible. People have to feel that we're not increasing biases by using these models. So we're actually at the same time developing a framework for responsible deployment of these models and then thinking about what's the best way to do it to have impact.
It's estimated that about 1 in 10 people in the world have diabetes, and they're projecting that in the next decade, that's really going to skyrocket. Why is this increasing so rapidly? And what role can AI play in helping the population manage the increase of diabetes?
Yeah, so there's a couple key features of diabetes which are really important. So one is that it's type 2 diabetes is preventable, potentially preventable. And we know this because there have been randomized controlled trials on if you can delay or prevent diabetes, and you can by up to 20 years. The other, though, tricky thing about diabetes, when I say it's preventable, it's not necessarily individually preventable, because some people are in environments that make it almost impossible for them not to be exposed to the risk factors of diabetes. So it's not an individual's fault necessarily, and I want to make sure that's clear. It can be the environment that can be very promoting to diabetes. And so there's lots of ways it can be prevented. And so the way we build cities has a role, as well as nutrition programs and physical activity and all the other things that we know are important for preventing diabetes. So it's one of those problems that really has the potential to be avoided if we can work together and work on it and address all the issues. The other thing is, once someone is diagnosed with type 2 diabetes, they're at high risk for complications like stroke or heart attack. And we also have very strong ways of preventing that. and very well evaluated tools. And we know that with monitoring and coaching, that those risk of those outcomes can be reduced dramatically. The problem is, though, that doesn't happen to everyone in the population. And there's lots of missed opportunities. So the reason why a tool that can identify people that are at risk for developing diabetes or at risk for complications is that we can really draw attention to those preventive factors. It's like, you don't want to have that missed opportunity. We have lots of problems we don't have solutions for. We have quite a few solutions for type 2 diabetes prevention, and knowing who would benefit from those solutions at the population level or at the individual level makes a huge difference.
And this type of a predictive model is a really new thing that we can apply at a really broad scale to bring help to a lot of people.
Yeah, there has been prediction models for diabetes for many years. And I've personally been working on predicting diabetes for probably about 15 years using different data. But what's really new is that we can now bring in more data sources. And the more data sources we can bring in, the more we're reflecting the true risk of diabetes and all the things that are impacting it, and getting better at predicting not just overall, but in very specific subgroups. So we're getting much better at that prediction and knowing what to do once we have it.
So in the next 10 or 15 years or so, as you see more folks coming into the field of epidemiology, studying public health, wanting to get involved, are you hoping that all of them have the ability to apply AI tools and machine learning tools to their work? Is that something that would help every part of the public health spectrum?
Yes, I think AI machine learning training should be mandatory for everyone working at public health. But I'll explain why, because I think some people might have objection to that. So at the core of public health is data, and how we use that data for our activities. And we know that we're generating more and more data than we ever have before. More of that data is digitized, and we're going to have to use some AI tools to work with that data. My concern is if public health is not involved, it's not only detrimental for public health, but it's actually detrimental for society. So when I give talks about AI in public health, I say at the end, public health doesn't need AI, AI needs public health. And the reason I say that is because public health thinks about bias, health equity, how we can improve the population, the societal impacts of what we do. These are all the questions people are having about AI more generally. And so if you have a discipline or a group that actually thinks about these on a regular basis, working more in AI, I think it'll help with some of the regulation that we need, some of the standards, and some of the warranted concerns that people are raising with AI. So yeah, it's my hope that everybody has awareness about AI, the good, the bad, and the ability to think critically about it, when to use tools, when to not. Again, as a help for the core work that public health does, not to replace, but to complement in really particular ways.
One of the things that folks might be thinking, listening to you talk about data and public health and how, in the frame of the last couple of years with COVID-19, I think I've seen a lot of headlines of, this group can predict the next pandemic, or this person's predicting the next pandemic. Are those headlines real? Do we have enough data now where we could effectively identify it sooner, faster? What's your sense?
Yeah, I mean, all headlines need to be taken with a grain of salt. Usually there's some sensationalization.
Yeah, it could just be a cantaloupe tweeting.
It could be. That would be a headline, actually, that I would be very interested in. There's never just one thing that's going to take over. But certainly if we're able to use data more quickly, process it, get intelligence from it more quickly, then yes, we will know these things much sooner. In terms of predicting the pandemic, that's kind of what happened during COVID-19, right? So there was a particular organization that used AI and travel patterns and was able to alert public health authorities very quickly in ways that we couldn't before. And forecasting models and mathematical models have been around a long time, but again, so what's happening here is an augmentation of it. We're able to feed more data into those models. We're able to bring in all that climate complexity, which really makes a big difference for pandemics. We're able to take into account travel patterns and where everyone goes and all these planes and all those people on them and what's happening where. So it's being able to bring that complexity in and make sense of it. And definitely, I don't want to say it's going to predict the pandemic because every pandemic, is unique, and it may be able to predict a potential pandemic. Some of these end up fizzling out and staying local, and some end up going global. And that's very difficult to predict, but definitely they will be able to identify emerging infections of concern more quickly. I have no doubt about that.
And conversely, would they not only be able to predict a potential pandemic, could these models be applied to predict potential solutions or preventative solutions sooner so that they can be considered by, the humans running countries and regions as they are managing through that time?
Yes. I mean, that was one of the rationale behind all the modeling that people saw in the pandemic. You can run different scenarios. And I think, generally speaking, those approaches are fairly similar to what we use before. But again, you can verify those assumptions with better data, and those models become quite a bit more powerful. So definitely you can look at all the different possible scenarios, the impacts. You can start blending in the health impacts with the economic impacts. And we did have some of those models during COVID-19. I think the bigger question is, and it kind of relates to what I was talking about before in the deployment side, I think we're going to have amazingly powerful models. Mm-hmm. Who will use them? How will they be used? How will the outputs of the model be weighed against human input, political influence? I mean, that's where the rubber hits the road. Mm-hmm. So we'll have these models. I think it's still unknown how they'll get integrated into a very messy decision-making, human-driven context.
And adopted into a health system or multiple health systems that run at their own pace and with their own different considerations. Do you see that being a barrier, the multiple different ways that systems work with health data and would adopt new technologies?
Yeah, we haven't gotten to a place where we have data harmonized in one place in most health systems, and there's good reasons for that. Health data is sensitive, so how it moves and how it gets shared is much different than other types of data. So we're very careful about that. So that's one of the reasons why it hasn't moved as quickly as it could. And, that's a good thing, I would say. Not that it hasn't moved as quickly, but that we're being very careful and thoughtful on how to do this. I know a lot of people lament about the slow uptake of AI in health and public health. I do think that we need to be very careful, mm-hmm. and we need to do it slowly, carefully, responsibly. The quicker we can agree on some standards and guiding principles of how this should work, and I think we're getting there, but we're not quite there yet, the better. I don't think we can just take the approach of, let's see what's happened. These are people's health. It's very sensitive. So I think that, yeah, the data is always going to be much more complicated in the health context. And I think most people who think about their own health data will understand that.
And for listeners that may be considering how they can play a role in helping, create safe regulations or policies, procedures, how to improve our healthcare system, healthcare delivery, just someone who isn't an epidemiologist and a specialist, what can they do to contribute to the positive outcomes that we want to see in applying AI and new technologies to the healthcare system?
Yeah, I think individuals have to be engaged and share what they would like in terms of how their data to be used and what they feel comfortable with. I think right now, and the good and the bad, I think there are some opportunities for public dialogue around the use of data. There's some great groups doing this, and I think these are really important. I think most people they talk about the functions that they want to see with their data. When they go to the doctor, they don't want to have to repeat themselves. They want all the information in one place. They want to be alerted when there's something that could benefit them. But what that means is sharing of data in particular ways. And so that's the trade-off that people have to think about, what they're comfortable with, what they're not comfortable with. Mm-hmm. And I think engaging in those discussions, when people think about these AI regulations, it is about themselves, mm-hmm. right? So really engaging in those discussions and making their voices heard.
So in listening to your description about how individuals should think about their own data and interacting with technology, it strikes me that, privacy isn't free. If I want to hang on to my data and not share it, that means I may not get the benefit of some of the systems that could really help look at my data, analyze it, and give me some great preventative tools or advice. So there's been a lot of talk about how we integrate chatbots or ChatGPT into the healthcare system. I think there may be some discomfort people have with interacting with a doctor robot as opposed to a doctor person and a human being. Have you seen that come up in your work? And how do you think about that at this moment in time as we're seeing this huge spike of utility of AI tools?
Yeah, it's a great question. So I will say on your first point about data, I think one of the things people are worried about, and it's a valid concern because history shows us that it does happen, is that if I do give you my data and you have some algorithm, it's going to actually impact negatively on me. So there's definitely positives, but there's also potential for negatives. So I think for us to move forward, what we have to do is really ensure there are processes and mechanisms in place to prevent against the negative. And as soon as we put those in place, the faster we put those in place, the better. And I know people don't want over regulation because that could stifle innovation. And I understand those points of view. But when I talk to people working in the health field and I talk to people, and even myself, there just needs to be some layer of protection there that says this isn't going to discriminate against me, or this isn't going to cause this or that. And I think there's ways to do that. It's not a difficult problem. Your question about whether people want to interact with robots, it's very interesting, actually. And it's pretty complex. So there are some chatbot applications in public health that's a very active area of research. So it's not exactly a robot, but on the way there. And they are in mental health or in smoking cessation or other applications. And the people that do this have found a couple things. So on the one hand, sometimes some people feel more comfortable talking to a chatbot or a robot about sensitive things.
Why?
Because there might be shame or stigma or other reasons why they feel uncomfortable talking to another person about this. Maybe they were judged about it in the past. So not everybody, but there is a subset. And then there is a subset that really feels uncomfortable, that they're really looking for that human empathy. And they're looking for, that piece about talking to another human being that I don't think we actually can quantify or describe what it is, but they're just looking for that empathy. And so I think for us, we have to think about when would interacting with a robot be okay and when would it not, and finding those right use cases.
Like, does a robot have bedside manner?
Well, so some will argue that for certain situations, it might have better or more consistent bedside manner.
Right.
But definitely, is it going to give you the empathy that you would get or the listening that you are expecting? Or am I going to start to mistrust it? All those are true. So I think we need a lot more human-robot interactions to be able to do this. I mean, we are seeing lots of applications. I said chatbots and also robots doing functions within the hospital, tasks, very specific task-oriented, as opposed to trying to be all things that humans are. I think that's much more realistic. And then you can study, is it optimizing for that particular task? One big concern with chatbots and generative AI, just more generally, is the hallucination, right? And there have been some unfortunate side effects of talking to a chatbot for very serious issues where they're sort of recommending things, they just kind of go off, which aren't what a human would be able to stop. So again, these aren't common, but there's enough examples of these out there that I think we need to proceed with caution. But there's definitely a role. I mean, definitely people have expressed interest and it could process things a lot faster for certain tasks, but we got to find out what those are. I don't think we've quite found those out yet.
I wonder, in the case of urgent care, for example, or an initial diagnosis of a situation, the role of a healthcare professional, a nurse or a doctor, may be to ask the right questions and really understand, and also get an instinct that, okay, I don't know if I have the full story yet. I need to ask some more questions.
Exactly.
Would there be limitations of the AI models or the robots, or would they be have more of a propensity to ask all the questions they need to get the data they need. What do you think that balance looks like?
I think there's limitations because you talk to any healthcare provider, they'll tell you that there's something like body language.
Mm-hmm.
So they can tell when something's not quite right, which is why, one of the challenges with virtual care, even, I have a lot of colleagues that are primary care physicians, for example, and they can just notice things when they're in person that they can't notice on phone. Some things you can definitely do over the phone more efficiently, and it's the same thing. So I think it's about finding the right use case. And what we don't want to do is apply this tool to everything more broadly. It goes horribly wrong. Then we lose complete trust in the technology and we throw at all applications, which is what I'm worried about. I think in health and in healthcare, we often start at the most extreme examples, high risk, predicting who's going to die, diagnosing a serious illness, diagnosing a very complex. These are all great applications that we want to be better at. But how about we start at how we integrate technology at some lower risk?
Small steps.
Let's figure out how to use it. Let's figure out how people work with technology and then work our way up. And eventually, we will get to these use cases, but
so in the COVID-19 pandemic, when we were working together on the CDL Rapid Screening Consortium, many times I'd hear you say, okay, it's the right test for the right application.
Right.
There's use the right test for the right moment. It sounds like use the right robot for the right moment.
That's
also
right. That's right. And the right AI technology for the right application.
Amazing.
That's right.
Welcome to The Debrief, the meeting after the meeting. We're joined by your host, Sonia Senek, and a couple of her friends from work, Amar Kaur and me, Elizabeth Chim.
Hello.
Hi, Sonia. What a great way to start with Laura Rosella.
Yes, public health education.
Or the cantaloupe that's tweets.
So the cantaloupe story is still very much alive. So what's the latest?
I think just the recommendation is do not eat cantaloupes. What I was trying to figure out, though, is if honeydew melon was okay. And I think they are.
I think they're a distant cousin.
But I'm just being overly cautious. Anything melon adjacent, I've been avoiding.
Yep, I dislike both of those fruits.
Sonia, I remember you were asking how does like a vegetable or fruit get salmonella contamination? So if you would like the explanation.
Yes, I do want the explanation.
Okay. So because of the way that we irrigate crops with water, a lot of the times contamination happens because of runoff from factory farms. So when you think of farmland, it has like tons of crops, but also livestock like cows, pigs, and chickens. And so the feces from those animals can contaminate water, and that gets sprayed onto the crops.
The interconnectedness of life continues.
Yeah.
And now we know. Always wash produce?
Yeah.
Oh, yeah.
Yeah, you should always wash your produce. I even still wash them when it clearly says on it pre-washed.
It's pre-washed, but it isn't post-washed.
I was going to say, I feel like after one of Laura's episodes, we always remember or remind ourselves about that interconnectedness piece. Has anyone had cotton candy since Laura told us?
Since last year when we talked about the goats
Yes.
and cotton candy story?
I have not.
Listeners, this is a throwback to many episodes ago of Going Viral with Dr. Rosella. For those who know,
Yes.
right?
Thank you. For those of you who know, thank you.
And so on that topic, I was wondering if any of you have a specific food aversion. Is there just a food that you have a very bad experience with, or just is on the bottom of your list for what you would ever eat? I can go first.
Go.
So when I was younger, I never liked liver to begin with, but it's a pretty healthy food, pretty nutritionally dense. One time I was feeling like very nauseous and I really didn't want it, but I had pretty stern parents and they made me finish my plate. And then I got incredibly sick, made a mess. And since then, I have never eaten liver.
No.
Wow.
Yeah.
Wow.
Do you have one?
I do. It's cantaloupe.
Really?
I hate it so
Perfect.
That's turned out really well for you in 2023 and 2024.
It truly has. And then as Elizabeth was talking, I was looking up how to say this, what I think is a Punjabi or like Indian vegetable in English. It's bitter gourd. I didn't know that it was just bitter gourd.
Yes.
Karela. Okay,
Oh.
so Elizabeth, so Sonia seems to understand the reaction, but parents love making bitter gourd. And their go-to thing to do is they'll stuff it with all these spices and they'll cook it with like potatoes. And to them, it tastes delicious because they'll put it in a roti wrap and just take it with them. It's like the go-to travel dish. Mom makes it all the time. She's like, try it this time. I'm like, Mom, it's still bitter. Like, it's in the name.
It's
bitter
very
gourd.
bitter.
I'm not having it. I am known in my family to eat anything vegetarian plus egg. That is the one thing I will not eat anywhere. That and cantaloupe.
You just triggered so many memories in me, even though we come from fairly different cultural backgrounds. In Vietnamese culture, we have something very similar with bitter melon.
Maybe it's the same thing.
I think it's the same thing. Bitter
It's the
melon,
same
bitter
thing.
gourd. It's this long, it looks like a very bad cucumber. And so in my culture, there's this specific soup that's made with it. You stuff the bitter melon, you cut it up into slices. And yeah, that is also on my list. And I've completely forgotten about that because I would never make that in my adult life.
Same.
But it does have a lot of health benefits. So it's shown that bitter melon or bitter gourd has properties that will actually decrease your blood pressure.
There we go.
So there's a trade-off. There's a reason why if it tastes so bad, it's because it's very good for you.
Can you check if chocolate milk also provides you with those types of benefits?
I don't think I need to check.
No, but I think there's something, and we can look this up somewhere. The start of this sounds very credible.
Please just text Laura right now.
Yeah, exactly. Can we just bring her back?